Imagine in a jet aircraft which contains an orange-colored wire essential for its safe functioning, an airline engineer in one part of the world doing a pre-flight inspection spots that the wire is frayed in a way that suggests a critical fault rather than routine wear and tear. What would happen next? I think we all know the answer. It is likely that probably within days, most similar jet engines in the world would be inspected, and the orange wire, if faulty, would be renewed. When will healthcare pass the orange wire test? In a world of columns, medicine is a divine profession, reaching out to people for replacing their tears with joys, transforming their lives. Yet, in this world of uncertainties, how safe are you? Disasters are random and unexpected. Statistics show less than 1 death per 100,000 encounters occur in nuclear power industry, the railroads and airlines. However, the risk related to healthcare errors is 100 times more. The impact of healthcare errors is 1,000 times more, making healthcare errors the 8th leading cause of deaths, ahead of car crashes, breast cancer, and even AIDS. In fact, this error rate is equivalent to 2 747 crashes every week. The number of lives lost from preventable medical errors in USA is up to 98,000 deaths per year, Canada up to 24,000 deaths per year, Australia up to 18,000 deaths per year. You can well imagine in India it will be much more. Patient safety is not only about statistics but involves damages to the lives of real people. To err is human. To cover up is unforgivable. To fail to learn is inexcusable. Safety has been a part of the system, but it needs exclusive attention. We cannot take it for granted. Recognizing that healthcare errors impact 1 in every 10 patients around the world, the WHO calls patient safety an endemic concern. The Department of Hospital Administration (AIIMS), in collaboration with WHO, has taken the lead to take forward WHO Global Patient Safety Challenge in India by launching the National Initiative for Patient Safety.
I feel privileged to be in this forum of medical professionals. I'm also extremely happy to be launching National Initiative for Patient Safety. The Institute of Medicine called for broad national effort to include establishment of Center for Patient Safety, expanding reporting of adverse events, development of safety programs in the healthcare organization, and attention of regulators, healthcare purchasers, and professional societies.
In the first workshop on National Initiative for Patient Safety in September 2009, I had proposed the formulation of National Infection Control and Patient Safety Policy. Today I am very happy to announce that an expert working group has prepared a consensus-based draft concept paper on National Infection Control and Patient Safety Policy. The basic premise of the document is patient care first.
My ministry has piloted the Clinical Establishment Regulation, Registration and Regulation Bill in Parliament. The bill had already been passed by Lok Sabha in the current session of the Parliament, and it has to be passed now on first priority in the monsoon session by the Rajya Sabha. Through this legislation, we are aspiring to create regulatory framework for all clinical establishment that would be entirely patient-centered. Just from one-man doctor to the big hospitals, both government, private, except for, I think our general is here, except for the hospitals which are under army, but all other hospitals which are under even railways and other labor ministry, except for that army, have private and government, they will come under the same bracket. Compliance with common minimum standards will be also the part of new legislation. The obligation to provide emergency medical care and creation of national database to be positioned in the public domain will all improve the quality of service delivery. This in turn would improve patient safety.
WHO, it's a panel of international experts for each topic, and the leadership and participation of India is always there and at the forefront. AIMS is our official and premier collaborating centers. It's a cherished partner to WHO. We are privileged to collaborate with the Union Ministry in all its important initiatives.
In 1999, the Institute of Medicine from US, they reported this facet of activities. That's how the American President Bill Clinton at that time looked into the recommendation of this committee and ordered this initiative for patient safety. And that's how in 2004 and various other countries also made studies and have found similar need that we need to look into the science of patient safety.
From this initiative, actually, we want to establish a network and establish a patient safety monitoring cell in All India Institute of Medical Sciences, which will monitor the progress of implementation of patient safety initiative in all the medical colleges in India. To begin with, we will start with the medical colleges, and slowly this will be expanded to all hospitals in the country.
What exactly is patient safety? Suffice it to say that it is freedom from unintended harm due to healthcare interventions. In our oath, we have said that we will prescribe regimens for the good of the patients according to our ability and our judgment, and never do harm to anyone. From this followed the directive principle, at first do no harm.
I think this is now an era of transparency where we all look at one another and we look at the things that we do well and we look at the things that we don't do so well, and its opportunities and challenges. And to me, the patient safety movement is something that we've done in our hearts all along. It is now, I think, appropriately being looked at as process and outcomes. As an infectious disease physician, it's simple things first. Obviously, washing hands and hand hygiene is one step that we all want to do, but not the only step.
From Indian standpoint of view, it's part of our culture. We wash hands before we eat and afterwards. We also greet each other with folded hands with namaste. So all of that is conducive to not transmitting infection from one person to another.
You have to use behavioral techniques, you have to make people empowered, they have to feel that how important they are and what they are doing has far-reaching effect on welfare of patients, because we absolutely believe that every healthcare worker wants the best.
That the master skills of surgery, the sharp clinical sense of the physician, and the unenduring service of the nursing staff are all lost to a microscopic bug. What we have done, it's a quality scorecard where we compile all the data. We are creating a benchmark, and mind you, we have the HAI rates and hand hygiene compliance rates and needle stick injuries and antibiotic usage in the scorecard.
The dangers that patients entering our hospitals and especially the operation theatres can face. We have all read reports of wrong side surgery, haven't we? It's front page news. Almost every second, third day you read about it.
They found that mortality and morbidity after these surgeries is very high. About 2/3 of adverse event is related to the surgical patients. 40% or even half of these mortalities and morbidities are avoidable. It means by numbers 1 million deaths and 7 million disabling complications, which half of them we can prevent.
2 million errors a year, out of which more than 100,000 people, they died. The other people were disabled. And this was all by the simple communication problems, wrong medications, wrong size surgery.
The rational use of drugs or medicines requires that patients receive medications appropriate to their clinical needs in doses that meet their own individual requirements for an adequate period of time and at the lowest cost to them and their community. We still use this definition today. It was made in 1985, and unfortunately it is estimated by WHO that perhaps more than half of all prescriptions may be incorrect, that more than half of all patients fail to take their medicines correctly. And more recently, we have done a more substantive quantitative review of all the medicines used in hospital outpatients and primary care in developing and low-income countries, and we measured that less than 40% of patients cared for by health professionals in the public sector and less than 30% in the private sector are treated in accordance with clinical guidelines as judged by local people, local professionals. So we really do have a very serious problem with regard to irrational use of medicines.
This is a case history of a patient. Very simple in bold. Okay? So just go back to your seat. Take 2 minutes if you want, just read it, and you imagine that you're calling me. I'm the consultant, I'm at home, and you're going to inform me about this patient. Imagine that you're calling me de novo, she has not called me. What would you say?
I got one patient at 9:45 p.m.
Yes.
Patient name is Ashok.
Yeah.
He's 35 years old.
Yeah.
Male patient.
Yes.
Was riding his.
This is the fundamental mistake that everybody does when they call or when they communicate on the phone. What I'm trying to tell you is that if I was the registrar and I was calling my boss, I would say, sir, I have a 35-year-old male patient whom I suspect has got hemiperitoneum following a road traffic accident. That would have been my opening statement. Yeah? Okay.
How do you address the training issues, simply put, so that we could minimize the impact of a new batch coming in?
It's a system-based approach, and standard orientation is what we have been striving for.
As a patient, I have yet to see a prescription where the diagnosis is written on it. It's only the medicine. Wouldn't the diagnosis help the pharmacist to be alert in catching any medication?
Yes, it is. One day session itself, how the OPD prescriptions are being given, how they are interpreted, and how it is being done.
We are barcoding the patient. We have the barcode. As a doctor, I put the medication in the computer. Nurse will go in the computer, scan the barcode, and see if the light turns green. The nurse gives the medication to decrease the medication level.
Now I see you have epaulets on, and I know the military is experts in execution. And if you read books about West Point and at the top leadership, they spend the first year breaking down one's self-importance as opposed to importance for the team, because you depend on each other to save each other's lives.
A doctor, nurse working in the emergency department using one glove from one patient to others. So what is that? They are protecting themselves and spreading the infection from one patient to the other.
We are acutely aware that it's an ambitious program. It deals with behaviors of health providers, and several of these are deep-rooted habits. We are aware of the challenges, and hence a proactive, sustained engagement with all providers at all levels will be necessary, and this is inbuilt in this intervention program.
If you take a patient-centered approach, it requires everyone on that team to be talking to each other, to be listening to each other, and making sure that the drugs and medications that are being given to the patients are the right ones.
I must stress that this aspect of communication skills is something that is not taught as yet in many medical colleges.
There are a lot of initiatives that can be taken to minimize the systemic error by the National Initiative for Patient Safety, which the All India Institute has taken up, will raise awareness all over the country, and I'm sure it's going to bring a beautiful change in the way we treat our patients.
And we see this public-private partnership where we have the private healthcare institution, government health institution, and the government really driving a great initiative. And we are extremely honored to be part of this initiative.
We are aware today of the problems created by the look-alike, same syringes for adrenaline and same syringes for other anesthetic agents, the sound-alike, diavolve, diamol, digoxin. We know today after this workshop there are 6 levels in which this mistake can occur. The number and magnitude of errors on a time scale, and to analyze the acceptance, attitude, knowledge and involvement of the physicians, nurses and paramedics for this medication management safety measures.
And what all errors we are facing in day-to-day life in our hospital. Some patient is having this problem, that problem in surgical side and clinical side. I think all those problems will not be there.
Clean care is safer care. We can achieve what we wish to if we proceed in an incremental, cascading manner.
Under the umbrella of National Initiative for Patient Safety, series of workshops are being organized to sensitize and help in implementing a patient safety program in hospitals. The immediate objective of NIPS is to train 80 to 100 medical colleges in a period of 2 years on patient safety, with the long-term vision of developing patient safety champions so that the message for safe care percolates to all healthcare providers throughout our country. Aspects of patient safety covered under the national initiative are surgical safety, hand hygiene and healthcare associated infections, medication management and patient communication. The medical colleges and hospitals are invited to send a team of 6 professionals from the Department of Surgical Disciplines, Anesthesia, Medicine or Pediatrics, Microbiology, Hospital Administration and Nursing.
Day 1 and 2 of the workshop are conducted by international and national experts who have implemented these core patient safety initiatives in their hospitals. Each session is followed by group work by the teams whereby they frame roadmaps for their hospitals on each area. These roadmaps are presented on day 3 to the panel of experts and peers for best practice sharing and learning. However, the real work begins after the conclusion of the workshop. These teams are encouraged to build a culture of patient safety in their organizations through these roadmaps. The organizers extend all possible technical help to the participants in implementing patient safety programs.
To err when you don't know better is forgivable. To err when you have the knowledge of something better is not forgivable.
There are miles to go, but we have started with a few steps in the right direction. NIPS, a workshop for patient safety in tertiary and secondary level healthcare facilities. NIPS, nipping the problem in the bud.